So thank you so much for being with us here, David. And I'll just give a little bio for our interns. So Dr. David Himmelstein is a professor in the CUNY School of Public Health at Hunter College. He received his medical degree from Columbia University, completed internal medicine training at Highland Hospital for the University of California, San Francisco, and completed his fellowship in general internal medicine at Harvard. Dr. David Himmelstein has served as chief of the Division of Social and Community Medicine at Cambridge Hospital and has authored and co-authored more than 100 journal articles, and 3 books, including widely cited studies of medical bankruptcy and the high administrative costs of the US healthcare system. His 1984 study of patient dumping or denial of services for economic reasons led to the enactment of the Emergency Medical Treatment and Labor Act, I think shortened to EMTALA. And this law ensures access to emergency services regardless of the ability to pay. Finally, he is a co-founder of Physicians for a National Health Program and is therefore one of the reasons we're all here.
So thanks. I guess I'm going to talk about a fairly limited topic today, not the more general issues that I usually talk about, and that's really quality problems and the approach to quality problems that have become widespread in our healthcare system. I'm going to share a PowerPoint. I think I have it here somewhere. Let me see here. Uh, there we go.
While you're getting that up, David, do you have a preference for how interns should ask questions? Like, should we wait until the end or could we raise our hand during the presentation?
Just butt in.
Okay.
Okay. Okay, so let's see here. Let's get it. Are you seeing my screen?
Yes.
Okay. And this, I need to move. Uh, Select master. Somewhere down here. Ah, here we go. Okay. Um, how about now? Is it full screen for you?
Yes, it is.
Okay. All right. So, I mean, the first thing to say is there are huge quality problems in our healthcare system. So this is sort of the classic Institute of Medicine, now called the National Academy of Medicine, study that was done in 1999 called "To Err is Human." One of the principal authors of that just died yesterday. One of the leaders in quality and safety um, issues in the U.S. And they estimated that at least 44,000 people die each year due to medical errors. So we're killing a lot of people with our substandard quality. And that was followed by a follow-up report from now the National Academy of Medicine that outlined 6 dimensions of quality. And I think I have those on whoop, on, thought I had those on the next slide, but actually, I guess this is the sort of the piece that the Institute of Medicine report in a way came off of, and that was the Harvard malpractice study that was published in 1991. And they looked at a random sample of inpatient hospital charts, and they looked for 2 things. One is, did the patients suffer an adverse outcome due to negligence? Um, and uh, second, was there a malpractice suit that resulted from that substandard care? And what they found is that there were about 90,000 deaths projecting nationally from negligent medical care. And of those, only 5,000 of the patients or their families sued. So there was a lot of malpractice of really bad quality care, but relatively rarely did those people actually sue. On the other hand, there were about 25,000 malpractice suits about bad outcomes of hospital care where there was no negligence. So one of the conclusions was that our malpractice insurance system or malpractice legal system was not an effective way of rooting out malpractice because in fact you were more likely to be sued if you hadn't made a mistake than if you had made a mistake in your care. So that led to that Institute of Medicine report. And by the way, those negligent bad things were not randomly assorted. So black patients were much more likely to suffer negligence than white patients, and poor patients much more likely to suffer negligent care than higher income patients. Um, and uh, Uninsured patients much more likely than Medicaid patients, and Medicaid insured patients much more likely than those with private insurance. So a lot of bad quality care, and really the fault lines of quality pretty much along the lines of oppression in our society. People of color, poorer people, and people who are second class coverage or no coverage in our healthcare system. Um, and Just to bring this up to date, a New England Journal of Medicine article from 2 years ago that tried to, as closely as possible with somewhat less resources, um, repeat some of the work that the earlier Harvard study had done. This was, again, colleagues at Harvard, David Bates and his colleagues. Um, and they found very similar things, that there were a lot of adverse events. Many of them were serious, many of them were preventable. And in fact, 1% of hospitalizations had at least one serious and preventable adverse event during that hospitalization. So, pretty close, in fact, to what that 1991 study had shown. Um, the response to these findings generally within the mainstream medical community has been to say we need to reward people for good quality care and punish them for bad quality care. And that's the way we're going to get out of this real quality cesspool that's characteristic of our healthcare system. And I want to just pause for a minute um, and show you a video that sort of was, in a way, my introduction to some of these issues in why pay for performance is such a bad um, a bad way to get at this. Sorry, it's going to go to my email apparently, but well, I guess it's going to go to here, but I'll switch to. Okay, are you now seeing the screen?
Yes.
Okay, so I'll play not all of this video, but some of it. This was my introduction to some of the theory that I then followed up on with research work. Wait 1 minute, because I think I forgot one thing here, which is I didn't turn on the sound. So let me do that now. Okay, let's try it this time. Let's see.
Our motivations are unbelievably interesting. I mean, I find I've been working on this for a few years, and I just find the topic still so amazingly engaging.
So are you hearing sound?
Yes.
Okay.
And interesting. So I want to tell you about that. The science is really surprising. The science is a little bit freaky, okay? We are not as endlessly manipulable and as predictable as you would think. There's a whole set of unbelievably interesting studies. I want to give you two. that call into question this idea that if you reward something, you get more of the behavior you want. If you punish something, you get less of it. So let's go from London to the mean streets of Cambridge, Massachusetts, in the northeastern part of the United States. And let's talk about a study done at MIT, Massachusetts Institute of Technology. Here's what they did. They took a whole group of students, and they gave them a set of challenges. Things like,
Whoops. Don't know what happened there, but hopefully it'll recover.
memorizing strings of digits, solving word puzzles, other kinds of spatial puzzles, even physical tasks like throwing a ball through a hoop. Okay, they gave them these challenges, and they said to incentivize their performance, they gave them 3 levels of rewards. Okay, so if you did pretty well, you got a small monetary reward. If you did medium well, you got a medium monetary reward. And if you did really well, if you were one of the top performers, you got a large cash prize. Okay, we've seen this movie before. This is essentially a typical motivation scheme within organizations, right? We reward the very top performers. We ignore the low performers and the other folks kind of in the middle. Okay, you get a little bit. So what happens? They do the test. They have these incentives. Here's what they found out. 1, as long as the task involved only mechanical skill, bonuses worked as they would be expected. The higher the pay, the better their performance. Okay, that makes sense. But here's what happens. But once the task called for even rudimentary cognitive skill, a larger reward led to poorer performance. Now, this is strange, right? A larger reward led to poorer performance? How can that possibly be? Now, what's interesting about this is that these folks here who did this are all economists, 2 at MIT, 1 at the University of Chicago, 1 at Carnegie Mellon, okay, the top tier of the economics profession. And they're reaching this conclusion that seems contrary to what a lot of us learned in economics, which is that the higher the reward, the better their performance. And they're saying that once you get above rudimentary cognitive skill, it's the other way around. Which seems like this kind of, the idea that these rewards don't work that way seems vaguely left-wing and socialist, doesn't it? It's kind of this kind of weird socialist conspiracy. For those of you who have those conspiracy theories, I want to point out the notoriously left-wing socialist group that financed the research, the Federal Reserve Bank. So this is the mainstream of the mainstream coming to a conclusion that's quite surprising, seems to defy the laws of behavioral physics. So this is strange, a strange finding. So what do? They say, this is freaky. Let's go test it somewhere else. Maybe that $50 or $60 prize isn't sufficiently motivating for an MIT student, right? So let's go to a place where $50 is actually more significant relatively. Right? So let's take the experiment. We're going to go to Madurai, India, rural India, where $50, $60, whatever the number was, is actually a significant sum of money. So they replicated the experiment in India roughly as follows. Small rewards, the equivalent of 2 weeks' salary. Small performance, low performance, 2 weeks' salary. Medium performance, about a month's salary. High performance, about 2 months' salary. Okay, so those are real good incentives. Okay, so you're going to get a different result here. Well, what happened, though, was that the people offered the medium reward did no better than the people offered the small reward. But this time around, the people offered the top reward. They did worst of all. Higher incentives led to worse performance. What's interesting about this is that it actually isn't all that anomalous. This has been replicated over and over and over again by psychologists, by some extent by sociologists, and by economists, over and over and over again. For simple, straightforward tasks, those kinds of incentives, if you do this, then you get that, they're great. For tasks that are algorithmic, set of rules where you have to just follow along and get a right answer, if-then rewards, carrots and sticks, outstanding. But when the task gets more complicated, when it requires some conceptual, creative thinking, those kinds of motivators demonstrably don't work. In fact,
right,
money
so
is a motivator
I'm going to stop
at
here.
work, but in a slightly strange way.
So that was my introduction to these issues. It's about 20 years ago now. And sorry about that. My phone is ringing and I'm not going to be able to answer it. I approached, well, let me share again here. So after I happened upon that video, I approached the guy who made the video, a guy named Dan Pink, who'd written a book about it. And I said, gee, I'd like to learn more about this, and like to do some more research in healthcare settings. And he said, the person you want to talk to about it is actually the people who did the research, not me. So Steffi Wilhelmer and I got in touch with a guy named Dan Ariely, who's a professor of economics and business at then at MIT, since moved to Duke, and we collaborated with him on a number of research pieces, and he taught us a fair amount about the literature on this. Um, and there's literature more in other fields than in healthcare, but I'm going to review for you some of the work that we did with Dan and that others have done as well, both in healthcare and elsewhere. Um, so the two biggest randomized trials of incentives for intellectual or cognitive work have been in schools. Are you seeing this slide, folks?
Yep.
Okay. So there was a $75 million randomized controlled trial in the New York City public schools. They randomized 200 high needs schools with 20,000 teachers in them to incentives up to $3,000 per teacher based on how well the students did on standardized tests, on graduation and attendance rates, and on surveys both of students and parents about learning environment and whether they thought the learning environment was good. Um, and what they found, the bars here are changed from baseline, and the blue is 1 year, and the yellow is 3 years. And the point here is that at 1 year, math scores both at elementary school and middle school levels went down somewhat. By 3 years, they went down even more at the pay for performance schools compared to the other schools. And the same thing with reading scores. So not only didn't it work, but as Dan Ariely's work would have predicted, um, actually things got worse with the incentives for teachers. There was another one done in Nashville, 296 math teachers who could get bonuses up to $15,000 per year per teacher, and based then just on students' test scores. There, overall, we found no effect of teacher incentives on student achievement. In fact, they went down a little bit, but not statistically significantly. Um, Now, there was a subsequent study of pay for performance in education that found slight improvement in test scores with pay for performance, but that wasn't by offering bonuses. It was by fining teachers if their students didn't improve. So they actually took away salary. They didn't offer any additional salary if if the students' scores went down. Now, in healthcare, we have only a very few randomized trials, but we've got some other kinds of evidence. So this is non-randomized data at 252 hospitals that were self-selected, that decided they wanted to participate in a Medicare program that offered bonuses if you improved not the outcomes, but the um, process of care measures, things like giving drugs that you're supposed to give for congestive heart failure or for acute myocardial infarction, AMI, pneumonia, coronary artery bypass grafting. So doing the things that you're supposed to do. And this study compared the hospitals that elected to participate in those bonus programs for Medicare to a matched group of hospitals that didn't. And what you see is that actually congestive heart failure care got a little worse for all of the hospitals, it turned out, but faster at the hospitals they were getting bonuses. And acute myocardial infarction care got better at, again, all the hospitals a little bit faster at pay for performance. Pneumonia care got better at all, but faster at the control hospitals. Basically, when you lumped them all together, it looked like the control hospitals did a little bit better on the mortality rates than uh, the pay for performance hospitals. Now, I said they didn't offer bonuses based on mortality. The bonuses were based on doing the things they thought you should be doing. But then the outcome they were looking at is, were the patients better off or not at the end of the experiment? And the point being, they weren't. Um, uh, Here, they were offering bonuses again from Medicare, not randomized, but self-selected hospitals participating in the bonus program, um, looking at infections from intravenous catheters or urinary catheters, and showing that uh, in general the bonuses had no effect, just to summarize quickly. Um, and This is not bonuses for doctors, but bonuses for patients. So there's been a vogue in big employers saying, we want to save money on healthcare by rewarding our employees who do stuff that's going to keep them healthy, and that's going to drive down our healthcare costs. So this was a randomized trial, um, at a giant corporation, where they offered bonuses to at some of their work sites and not at others, for doing all the stuff that we think should improve patients' outcomes. So for losing weight, for improving your diet, for stopping smoking, for taking your blood pressure medicines. So all the stuff that doctors say, gee, if we could just incentivize patients to do those things, we could get them better. And in this randomized trial with, I think it was 100 and some thousand patients, basically there was no improvement at all. Um, so if you offered incentives for the patients, that didn't work either. Um, Medicare adopted pay for performance as its kind of preferred quality improvement strategy. And one of the early pieces that they did was, they said, well, if a patient gets readmitted to the hospital after they've been in the hospital, um, that's a quality problem. At least if you have high rates of that, it's a quality problem. So we're going to reward hospitals that don't readmit many patients soon after they're discharged, and we're going to penalize hospitals that do readmit patients in large numbers. Um, and what early results showed that it was working, that the readmission rates were going down dramatically. So, oh, there was a declaration that this is working. And Steffi and Dan and I actually looked at the question, well, was it really working, or were the hospitals playing games to make it look like it was working? So it turns out, when Medicare says someone's been admitted to the hospital, there are two ways you can stay overnight in the hospital, and Medicare classifies those differently. One is what they call an admission, and the other is something they call an observation stay. An observation stay was originally because when they started paying hospitals a set amount per hospital stay based on the diagnosis, so you got $10,000 for a pneumonia patient and $25,000 for a hip replacement. Um, the Medicare started saying, well, there's a problem here, which is hospitals will just admit patients who they know are going to be discharged very quickly, and they'll collect the full amount, even though the stay is very short. And they may be admitting some patients who don't really need to be in the hospital in order to collect more of their money, or more of Medicare's money. So we're going to declare that a stay that's less than 24 hours is and observation stay. And then they changed the rules a little bit so that the hospitals could designate someone as observation even if they were going to stay longer than 24 hours. And why would the hospital do that? Well, it was bad for the patients because if you declared someone an observation stay patient, they were responsible for 20% of the bill. And if they were an admitted patient, the patient actually was responsible for a much smaller piece of the bill. So, in general, hospitals weren't designating patients as observation stays unless they were going to be very short stays. And Medicare was auditing things to see were very short stay patients actually being designated observation stays. But it turned out after they started saying we're going to penalize you for readmitting patients, hospitals dramatically increased the number of observation stays. That didn't count as a readmit according to Medicare. And when we redid the statistics on how many people were readmitted, it turned out when you included observation stays, there was virtually no change. So hospitals were not actually stopping patients from being readmitted. What they were doing was relabeling them observation in order to make more money. Um, now, one of the things that's striking about this is that the mortality rates for two of the conditions that were subject to these incentives actually went up after the uh, after the incentives came into effect. And we think, and there's fairly convincing evidence, uh, this is because patients were coming to the emergency department and the emergency department would say, this is a readmission patient. We're going to get penalized if we readmit them. And maybe that we could designate them observation stay, maybe not, but best to send them home in terms of our finances. And in fact, the mortality rates of the patients went up. That's not disputed. And how do you do this? Well, at hospitals around the country, ERs then had on their, as part of their electronic medical record, a pop-up that would come up. This patient has been discharged within 30 days. Consider whether you want to readmit them. So this was the guide to hospitals as to triage them into going home or observation stay or something else that was financially beneficial but not good for patients. Um, and this is sort of another study showing again higher 30-day mortality after the a higher 30-day and 1 year mortality after the penalties for readmissions were instituted. Um, uh, Again, sort of cementing this more in place, um, myocardial infarction mortality rates had been going down until the readmission penalties were announced, and then the line flattened out. So it turned out that you stopped progress with this penalty, this pay for performance penalty, and the curve resumed its downward trend, but it took 2 years before we recovered, and by then we were off the previous curve, and probably several thousand people died as a result of this penalty. I'm going to skip over that one. Um, Now, um, what causes readmission besides medical errors? Well, it turns out if you look at who gets readmitted, poor patients are much more likely to be readmitted, unemployed patients, patients with little social support at home. If you've changed your address in the prior year, if you've not adhered to what the doctor suggested you do, if you smoke or if you're a substance user. Um, why would that lead to readmission? Well, if you live in a fifth floor walk up and you have congestive heart failure, you're much less likely to be able to make it at home than if you're in a luxury building with an elevator and people to help you at home. Smoking for obvious reasons, substance use for obvious reasons. So, um, really, in part, what these readmission penalties were doing was penalizing hospitals for the kinds of patients they took care of, not for their quality of care. So if you cared for oppressed patients, you were likely to be in more trouble. Um, there's experience not just in the US with some of these things, but in other countries as well. So this was a study that was done in England where they rolled out pay for performance bonuses to hospitals, um, and they rolled them out region by region. So some regions um, were late beginners and others early beginners. And what they found is the early beginners, that blue set of bars, all of a sudden their mortality rate went down after the pay for performance bonuses began. So this was published in the New England Journal as this is a success. We're driving down mortality. What they found is that uh, the longer term follow up. So after a year and a half, they went back and looked at what happened, and it turned out that the curves had separated again. So the pay for performance hospitals actually weren't doing any better than the non pay for performance hospitals or the late adopters. So what they found actually was their initial claim that pay for performance bonuses were cutting hospital mortality wasn't true. They basically, to their credit, came back and said we were wrong. Um, UK instituted pay for performance for family doctors, for their primary care doctors, in the largest pay for performance program in the world, actually. And there were 146 things that a doctor could get rewarded for. And by the end of the first year, the doctors had gotten 96.7% of every possible bonus. So the doctors did everything that they were supposed to do. They increased their incomes by 25% by doing that. Um, and here was the initial finding. The scheme accelerated improvements in quality for 2 of 3 chronic conditions in the short term. However, once targets were reached, improvement slowed, and the quality of care declined for 2 conditions that there weren't incentives for. So the doctors were meeting the goals for the things they were getting rewarded for, until they had met all of the rewards. So if you got the bonus for saying 90% of patients got advice to stop smoking, once you hit 90%, they didn't improve any more than that. And for things they weren't getting paid extra for, those things they were getting worse at. Um, Now, it turned out, for instance, they said they were controlling the blood pressure of all of their patients. But then someone said, well, let's do a household survey on what's happened to blood pressure. And what they found is that blood pressures actually, when you measured them at home, patients weren't better. So the doctors were claiming they had controlled everybody's blood pressure and they were getting paid for it. But actually, the patient's blood pressure wasn't any better. Um, and if you looked at stroke, the most feared in a way um, high blood pressure outcome, again, there was no change in the number of strokes in the country. So what it looked like is that the doctors were either lying or fooling themselves, that they were checking the boxes on the form to get the incentives, but actually the patients were no better off. So how could you do that? Well, one of our colleagues who works at uh, a primary care practice that's actually owned by United Healthcare, the giant insurance firm, told us how they were told to deal with blood pressure in order to get all of the bonus points that Medicare now rewards for controlling blood pressure and many private insurers in the US. So you tell your medical assistants, who generally take the blood pressure and record them in the electronic medical record, keep checking the blood pressure until you get a reading below 140 millimeters mercury and then stop. Now that gets you the bonus if you're below 140. Blood pressure varies moment to moment, so it could be 145 one minute, 139 the next. Um, what's the right blood pressure? Well, it's probably the average of three readings taken properly. But here they're not taking it properly. They're actually just saying, let's figure out how to get it below the threshold that gets us reward. Um, any of you who've taken blood pressures will know that you're watching either a column of mercury or a little pointer on a dial move, and the difference between 140 and 139 is essentially no difference. But if you teach the people taking the blood pressure to say, when it's roughly that, call it 139, and you get the bonus if the blood pressure is above the threshold that you want, but you record in the chart that you did something, like I told the patient to eat less salt. Um, so that gets you the points. Or the other thing you can do as a primary care doctor is you can fire the patients who who whose blood pressure remains above your threshold. And all of those things are going on. So we're turning doctors into cheating. Now, um, the most recent review of the effects of pay for performance in the British National Health Service, published last week, reported quality for incentivized indicators improved at 1 year, but gains were lost by year 3. For outcomes like blood pressure control, improvements were small and mostly not significant. So the things that you could get the bonus by just checking a box, that improved at 1 year but didn't improve at 3 years. But things that were more outcome measurable, like blood pressure, there were small and not significant improvements. Measures not incentivized worsened by year 3. And when incentives were withdrawn because they had a rotating set of incentives, quality fell back below the baseline. So the British system looks like it's been a monumental failure. Um, I'm going to skip over that and skip over that. Um, well, we have similar kinds of things. This was a randomized trial in clinics in New York. And what they found is that things that the doctors reported on leading to bonuses, like, did I tell the patient they should be taking aspirin when that was something that was recommended by algorithms? Did I tell people who were smoking they should quit smoking? That the doctors were doing, or at least they were claiming to have done them. But the patient's cholesterols were not lower, despite the doctors saying they were prescribing cholesterol lowering drugs more. Um, and the rates of cardiovascular disease, um, actually, blood pressure control didn't improve. So things doctors could fake were improving, things that were harder to fake were not. Um, I'm going to skip over this one. Um, here's in the Veterans Health Administration. So they started rewarding VA doctors for counseling patients about unhealthy alcohol use, and the doctors documented counseling much more frequently, went from 59% to 83%. But if you ask patients were they being counseled, very few of them had any memory of being counseled. There was essentially no change during that same period, according to the patients' accounts of what had gone on. Um, and if you look at the Medicare quality measures, so we now reward doctors in Medicare for meeting a set of quality measures that Medicare specifies, like counseling on smoking and controlling blood pressure. Um, doctors who had high scores, that's the left-hand set of bars, the mortality rates were actually higher than than the doctors with lower scores. Um, well, um, the head of the VA, former head of the VA, in summary of some of the experience there, said it's the same pathology that perverted things then. As soon as you tie metrics to pay or performance, they became subject to gaming. The doctors were gaming them. Well, I'm going to skip over. Actually, let me go through this one. It's the other fairly large randomized trial in the U.S. Um, they gave doctors $1,000 per patient um, for improving their cholesterol levels, patients with high cholesterol. So, on average, doctors in the study had 5 patients who were eligible for the study. They could get bonuses of $1,000 per patient. And they offered patients bonuses. They said they could win a weekly lottery if their cholesterol level actually was going down, and if they were taking their medicines as prescribed. Now, how did they know that they were taking their medicines as prescribed? They had electronic bottle caps on the medicine that recorded each time the bottle cap was opened. So the patients could get up to $100 a week for opening their bottles more frequently, basically. Um, uh, the LDL dropped 33 milligrams per deciliter in intervention patients, 25 milligrams in controls. As a primary care doctor, I can tell you that's a statistically significant and clinically insignificant change in LDL. So the researchers declared this a win, but in fact, clinically, it's not a win unless the patients did better, and they had no data on outcomes, nor on the other patients in the doctor's practices, nor on what else the doctors were doing. Um, Moreover, when they published it, the follow up at 12 months, there was absolutely no difference in cholesterol levels. Though the patients were opening the pill bottles, maybe they'd realized that's how they could get the bonuses. Their cholesterol wasn't going down. Well, I'm going to step back a minute, um, and I'm going to talk about really 5 assumptions that lie behind the pay for performance. Let me just ask, how long do we have? When should I be planning to stop?
This talk is scheduled until noon.
Okay. Um, so 5 assumptions that underlie this. One is that you can accurately measure performance. A second is that the current payment system is too simple. Third is that variation in performance is caused by variation in motivation. Fourth is that financial incentives will add to the motivation, not undermine it. And fifth is that hospitals, doctors that aren't doing good quality care should get fewer resources and not more resources. So I'm going to go through each of these assumptions. Um, the first is that performance can be accurately measured, that the variance attributable to an individual doctor can be differentiated from that due to the nature of her patients, her practice setting, or the ability to game the system. So, um, this is a study. Um, Actually, I'm going to skip over that one. Um, this is a study done a number of years ago at Massachusetts General Hospital. These are all Massachusetts General Hospital doctors, and we think that there's not significant quality differences among the doctors. Yet, if you looked at the patients, uh, among the top scoring doctors, 14% of their patients were people of color. Among the bottom scoring on the Medicare quality measures, 26% were people of color. Among among again non-English speaking patients, looked like if you had more non-English speaking patients, your quality scores were going to be worse. If you had more uninsured and Medicaid patients, your quality scores were going to be worse. If you had patients who made infrequent visits, your quality scores were going to be worse. And the conclusion the researchers drew from this study was that the quality scores told more about who the patients were than whether the doctors were actually good doctors. So if you had patients whose life circumstances made it much more difficult for them to actually do what we think ought to lead to good health, then it made the doctors look bad. So we were penalizing the doctors not for their quality of care, really, but for taking care of patients who needed the care the most. Um, Same thing for surgeons. If we looked at poorer patients, um, the risk adjusted mortality of the poorest patients compared to the richest patients among surgical procedures is significantly higher for poor patients than for rich patients. And we think this is not because of the surgeons. These were the same surgeons actually, but because of the life circumstances and baseline health of the patients. Um, if we looked at is there honest reporting? And for a lot of these measures, it's very hard to tell whether the reporting is honest or not. But here, some researchers at Brown Medical School figured out a way, and that was how many elderly patients were prescribed drugs that generally should be avoided, not in every case, but generally should be avoided. So high rates of prescriptions is generally poorer quality care. And the green is what the hospitals were reporting. Uh, Actually, Medicare Advantage plans at this in this one, and the yellow is what the drugstore records actually showed. And what you see is that the hospitals were cheating. They were reporting many fewer drugs that they were should be avoided, and that they therefore would get penalized on than was really the case. So again, here not the nature of the patients, but the nature of the cheating that is being revealed. Um, this is the 30-day readmission rates reported by hospitals to Medicare, as opposed to going through the hospital records for those hospitals. And you see again evidence that they were cheating to meet the bonuses. Um, I'm going to skip over that one. The same kind of alcohol counseling slide that I showed before. Um, well, Medicare also rewards hospitals based on what's called quality of care surveys. So they survey patients who've been admitted to hospitals and ask them to rate their hospital stays on a scale of 1 to 5 on a variety of different measures. And there's a consulting firm that actually will then, for a large fee, tell hospitals how you get patients to rate you as 5, not by improving your care, but for instance, by having these buttons that everybody in the hospital wears that says, how can I make your visit a 5? Um, I strive for 5. Here's a letter or a card that someone got after their hospital stay. Thank you for choosing Advocate Trinity for your echocardiogram. This is the technician who performed the echocardiogram. It was a pleasure to meet you. I strive for 5. And this we strive for 5, very good. So this arrives just about at the time that the satisfaction survey arrives. Turns out that a score of 5 is virtually a necessity if you're going to get any of the bonuses. A score of 4 puts a doctor or hospital in the bottom 1% of all hospitals and doctors. Um, this is the Medicare ratings of nursing homes. Um, 5-star nursing homes attract more profitable patients than 4-star. They are $1,000 per bed more profitable. But they often, it turns out, submit false data on staffing, antipsychotic medicine use, and adverse events, which are supposed to be reported to Medicare honestly, but they cheat on them. Um, they're as likely to flunk in-person inspections as to pass. And the Medicare was warning them of so-called surprise inspections. Um, and more than 2/3 of the top-rated nursing homes actually failed infection control or patient abuse standards. So the Medicare ratings were in effect wrong. This is a study in New England Journal of Medicine. How are you going to compare hospitals to one another? Well, one hospital that admits very sick patients because they're a tertiary care hospital caring for desperately ill patients, you'd expect their mortality to be higher than a hospital that's not caring for very sick people on average. So you have to risk adjust. So how do you risk adjust? These researchers compared 4 different measures for calculating risk hospital-wide mortality um, in order to risk adjust. And what they found is that 12 of 28 hospitals had higher than expected hospital-wide mortality when classified by one risk adjustment method, but lower than expected mortality by classified by one or more of the other methods. So depending on which of the risk adjustment algorithms you used, a hospital could look very good or very bad. Well, how do you look good on some of these things? Um, you make the patients look sick by saying they're they've got a lot of diagnoses, and both hospitals and insurance companies get paid by Medicare under the Medicare Advantage program. The insurers get paid based, they get more for patients with more serious or more diagnoses. So if you maximize the number of diagnoses you report, you get more money. And on the risk adjustment methods, you look better because, well, the patient was sicker to begin with. They had all of these other problems. I'm going to skip over that. Here's one hospital that I actually used to work at, and our risk adjusted mortality was 1.42, so 42% above expected after adjustment for risk. And the hospital administrators spent $500,000 on a coding consultant. They put nurses on every ward, not to improve the quality of care, but to tell the interns, you've written the wrong things in the chart. You need to write things that make the patients look sicker. And our quality adjusted mortality came down dramatically within 3 months, and within 6 months we were better than average, 14% below expected, and we got more money for it. The interns, it turns out, were writing things like acute kidney insufficiency rather than acute renal failure, magnesium 1.6 rather than hypomagnesemia, all these other things that are synonyms, but the left-hand set of things didn't count against the risk adjustment formula Medicare was using, and the right-hand set did. So you can up your reimbursement by recording more diagnoses, and you up how good your mortality rate looks after risk adjustment. I'm going to skip over that because uh, we're going to run up against time. The second assumption that I talked about is the current payment system is too simple. More detailed contracts that reward specific aspects of performance will improve quality. So there's a long literature in the economics um, literature on what's called incomplete contracts versus complete contracts. So incomplete contracts lay out the general parameters of what's expected, like spend 30 minutes with a patient. But the details and expected contingencies are covered by social and professional norms. So we expect you to be a good doctor. We're not actually going to monitor every individual thing that you do and reward you based on that. Intrinsic motivation, the feeling that doing good work is why you wanted to be a doctor to begin with, helps drive adherence to these norms and maintain the goodwill needed to resolve problems that might arise. There's again a long history in economics of this, um, as compared to so-called complete contracts, where you specify all the parameters of an exchange. Something that's not specified uh, doesn't matter, and it's very expensive to keep track of all of these details, both for the doctor and for the agency that's paying them. And again, this is not just in medicine, but elsewhere. Dan Ariely, whom I spoke of earlier, told us that when he first arrived at Duke, he asked the dean of the law school, "What does your honor code say?" And the dean said, "It says don't do anything that you would be ashamed of." And Dan said, I asked him, why don't you be more specific than that? And he said, if we told him you can't have chickens in your dorm room, that would say it's okay to have pigs in your dorm room. Um, we don't want to specify because anything that's left out is open to them doing whatever they want. Well, the effort to specify more and more of what we care about in healthcare is part of the growth in managers that's seen on this slide. So the blue is the number of managers in healthcare, and the yellow is the number of doctors. The other things driving this are the increasing profit motive in healthcare. So extracting money is expensive, whether it's detailed auditing or not. Uh, and enforcing inequality in healthcare is also expensive. Um, Third assumption is that individual variation is caused by variation in motivation. If you're not doing good work, it's because you're not trying. So uh, if your poor performance isn't because you're not trying, then incentives aren't likely to change it. Um, and related to that, financial incentives will add to your motivation, not undermine it. Well, motivation, the behavioral economics and social psychology literature talks about two kinds of motivation: extrinsic motivation. So if I pay you more, that'll make you want to do it more, or punishment, that'll make you want to do it less. Um, or intrinsic reward, things like taking pride in your work, getting joy out of a patient doing well, or feeling grateful to you. What Don Berwick, one of the quality gurus in healthcare, has said: it feels good to be a good doctor and better to be a better doctor. Um, well, um, the uh, Dan Ariely did a series of studies actually looking at some of these questions, and he put it to us. If you ask someone, will you help me move a sofa? This is a picture of people actually moving a sofa on the New York City public transportation system, the subways. Um, would you help me move a sofa if I'll pay you $3? And the way he put this to us is, if I invite you to dinner and at the end of dinner you say, that was a really nice dinner, I'd like to give you $10 as a reward, that's an insult. That's actually not a reward. Or as Uwe Reinhardt, one of the really best American health economists once said, do we think giving doctors tips is what's going to make them want to do good work? Um, well, Dan did a series of studies in this. Here's one from daycare centers where they had fines for late pickups of children. Um, and Initially, they had no fines for picking up your kid late, but half of the daycare centers instituted fines and half left it. You didn't pay anything, you were just doing bad to the staff. And what he found is that when you instituted fines, late pickups actually increased. It became, if I'm 20 minutes late, I'll just pay a little extra, no big deal, as opposed to I'm screwing the staff. Interestingly, when they abolished the fines, the late pickups didn't go back down. So once you've poisoned the well, you can't unpoison it. Um, and this is the data from that study that was talked about in the video, basically showing that rewards made things worse for math problems, but not simple manual things. And there's a raft of studies showing the same things. Tangible rewards undermine motivation for tasks that are intrinsically interesting or rewarding, but symbolic recognition like praise or flowers may augment it. And the negative effects of rewards are stronger for more complex tasks, and they tend to reduce reciprocity and augment selfish behavior. So that's stuff that when you're uh, things that aren't being rewarded get worse. Um, Avidus Donabedian, who in the 1960s really founded the healthcare quality movement, wrote, systems awareness and systems design are important for health professionals, but are not enough. It's the ethical dimension of individuals that is essential to a system's success. Ultimately, the secret of quality is love. You have to love your patient. You have to love your profession. You have to love your God. He was a religious man. If you have love, you can then work backward to monitor and improve the system. And he railed against quality bonuses. Um, uh, if you look at, um, actually, I'm going to skip over that one. The last assumption implicit in pay for performance is hospitals and physicians that are doing bad work should get fewer resources. This is King Drew Medical Center in Los Angeles, and they were doing really bad work. And as a result, they had their Medicare funding and Medicaid funding dramatically reduced, and they got closed. And the result was that a region of Los Angeles with 1.2 million people had no hospital. And here's how long it took to get to the nearest available hospital for people who from King Drew. So it was an hour by public transportation to the nearest alternative. Um, and essentially, what the message was is we're going to make the community's care worse by taking away resources from a hospital doing poor work. Um, Here's the hospitals that got some of the poor, I'm sorry, some of the worst um, penalties under Medicare. Um, and uh, Here are the poorest counties in the United States that got the worst penalties under Medicare programs. And if you know your history, this is cotton country. This is former slave country in the United States, the highest and worst concentrations of slavery in our country. And basically, this is the most impoverished parts of our country today. And what Medicare was doing was taking away the the hospital resources from the poorest people in the United States. Um, and if we look at the results of that, it wasn't just King Drew that had uh, had a closure. 90 rural hospitals um, have closed since 2010. This is old data. We now have many more. A third were more than 20 miles from another hospital. We have large deserts for medical care growing up in our country now, uh, decided by the market and by incentives that have been put in place by pay for performance. So um, I guess my message is we have enormous problems in quality in our country. And the tack that's been taken by our health policy to say financial rewards and penalties is the way to deal with that is exactly the wrong thing to do. It's making things worse, not better. What we need to do is actually take money off the table and say we need to incentivize people with love and symbolic rewards to get them closer to their communities, not have them striving for money. So I've gone too long. I apologize to you. Um, we have a few minutes left.
Thank you so much. I think the message is quite clear after your talk. I can start us off with some questions. So I was just wondering, when you were talking about like mortality levels with CHF and pneumonia, and the doctors making the decision to send the patients home, despite maybe like them not being in the place to be sent home, like would the doctors be making that decision because they're receiving pressure from like hospital administrators? Okay, that's what
Yeah,
I had hoped.
generally, no, I think the most dramatic example of that I ever heard. So when we did, I think it was talked about a study when I was an intern on patients refused care at hospital emergency rooms because they couldn't pay. And 60 Minutes actually picked up the story and had a long spot on it. And they got a recording from a phone of a public hospital doctor being referred a patient from a private hospital emergency room. And the public hospital doctor says to the doctor referring the patient, doesn't sound like the patient's stable. And the private hospital doctor says, look, this is an ever loving, profit driven hospital I'm working at. They're coming down on me hard to get rid of these patients who are money losers. So that's the most extreme form. But the message is clear to doctors around the country. If you're making money for your institution, uh, you're welcome. If you're not, you're in trouble.
Thank you. That's really sad. Zachary?
This is just a clarifying question. Are these pay for performance schemes still largely the primary method of quality like improvement and management in healthcare, or have they been replaced?
They are still very much current.
Okay.
People have stopped studying them because there's so much data that says they don't work. Why bother studying them anymore? And there's no control group anymore. Everybody has them.
Therese, go ahead.
I was just wondering what you think are the best ways to improve quality moving forward, or is this something that's just mostly systemic and has to do with um like current healthcare settings?
Yeah, so we need to monitor quality of care. We need to collect data on quality of care, but we don't need to reward people. So Don Berwick, who I said was kind of the guru on quality, once said, if you want to pay doctors for anything, pay them to tell you about their mistakes. Um, so, we need to create a climate where the 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 folks who wrote that 1999 Institute of Medicine Quality Chasm report said um, uh, an error is a valuable thing. We need to encourage people to report their errors and to create an environment in which people bring forward their errors and we can all learn from them. And that's, I mean, we need to collect the data to learn from them. We need to get people to bring them forward. And then we need to not punish them or reward them. We need to say to them, that's great that you've admitted your errors. And here's an error, here's a problem that we see in our institution where we're delivering poorer quality care. We all want to improve that. We've collected the data and we can see how we can improve by collecting that data, not because we're going to make more money, but because that's what's right to do for our patients and it's what feels better for all of us. None of us go into this profession because we want to do harm to patients. We go in wanting to actually do good work. So if you arm people with data about how they can improve work, you set up systems for how they can improve their work, they'll want to hop on board. But the finances interfere with that.
And Anna, did you have a question?
You just answered it, David. Thank you. I was going to ask about what alternative ways of improving quality would be, but
Yeah, so I mean, there's a science for quality improvement that folks like Don Berwick and others have really developed over the years, which involves no money, but it's saying we need to have detailed data collection, not of the trivial things that we are awarded for, but of things that patients care about. What are our infection rates? Not so we can game them, but so we can change them. What are our surgical complication rates? What are our readmission rates? Not so that we can get a bonus, but so we can find out who we're sending home that we shouldn't be sending home. And and those things can then be systematically fed back to the clinicians with staff. One of our friends who has done quality improvement work at ICUs both in New Mexico and now at Dartmouth has really done that kind of work in the ICU in a striking way. But the hospital eventually said to her, "We don't want you doing that. You're not making money for us."
David, I do want to be cognizant of your time. It's 12:03. Like, do you have time for like one more question?
Yeah.
Okay, Mackenzie, go ahead.
Hi, thank you. I had a question about the alternate approach that you just talked about. If there was low quality measurements in a hospital with poor resources and the only way to address it was by increasing some kind of financial resources, do you think there's a concern that that could be misconstrued as a reward for low performance and then lead to problems of its own?
Um, you know, I guess depend on how the system was structured. If it was that everyone collects data and then there's a sort of if you're bad enough, you get so much more data. Um, but if it's that we're allocating funds for hospitals based on a wide variety of features, like how sick their community is, not the things they report, but the level of illness in their community. And things like their staffing levels. Do they not have enough staff? Do they not able to modernize their facilities? So my children actually, who are both doctors, did a study looking at the capital resources, so the value of the buildings and equipment at minority serving hospitals. And what they found is that minority serving hospitals had much less in the way of buildings and equipment, like 30% lower value of the uh, dollar value of the buildings and equipment available. So that's the kind of resources that you say we need to equalize those resources. Minority patients need more resources, not fewer resources. And you have to have a rational allocation system for I mean, that's why we want single payer, or part of why we want single payer is to have a health planning system that directs resources to where they're needed. And problems in quality that are lack of resources, yeah, they ought to be addressed by adding resources. So if you can demonstrate for instance, that the value of your capital stock, you don't have the MRI machines, your buildings are old, you need the money to upgrade, then that's the right way to allocate those resources. Anything else? Well, thanks, folks. Good luck. Have a good summer. Enjoy as much as you can. Don't study too much. And um, we're in a dark period in American history, but things will get better. So we need you folks to lead us to there.